Actually, Dr. Saravanan needs no introduction. He is the HOD of the retina unit for many years in Aravind Eye Hospital, Coimbatore. Fantastic vitreoretinal surgeon. Trained so many people. Actually, he should not have been called for a medical retina topic, but more for a surgical topic. But fortunately or unfortunately, we have only that this thing to come. So, sir was the first VR surgeon from Aravind, and he's had outside postings. He's trained a lot of people. We are very honored to have him here today. So I'll invite him for the keynote address.
Thank you, madam, for the kind invitation as well as introduction. So this will be just go through some of the treatment options which have happened throughout the years, at least during my both learning as well as now current scenario. So as you know, diabetic macular edema is one of the commonest causes of vision loss amongst working age population. So it's approximately it's 18.18 million people are suffering from diabetic macular edema in the year of 2020, according to one of the assessments. So this is the number one cause of vision loss in where the person is working. Like if they are in the top of their professional ladder, they may be a dean in a college, or they may be a manager in the office. So that's the time when this hits them most, and they tend to lose a lot of work as well as professional difficulties carrying on with their when they are at the peak of their career. So as you know that we have two types of damage happening in diabetic retinopathy. One is because of leakage as well as because of ischemia. And ischemia causes the bleeding complications, where leakage causes the edema complications. And conventionally, this is how we have been treating with the focal laser or grid laser for the DME, as well as pan-retinal photoablation for the bleeding complications. So these were the older options which we had. And you can see this is one short video showing the laser being applied. So in the olden days, we never aimed for vision improvement. We just happy with the vision stabilization. And focal laser was mainly aimed at stabilizing vision. Only a few percentage of people tended to improve in vision. And usually it takes more than 3 months for the hard states to resolve. And this is how it happens after the treatment. For a complete resolution, it may even take more than 6 months also. So you can see here, this is what we were initially doing for these guys. But you have to remember that edema is not a constant disease. If the sugar control is super good, then the edema resolves on its own. But we are creating permanent scars by doing laser treatment. So the collateral damage, both in loss of visual acuity as well as color vision and as contrast sensitivity, everything was very bad with focal laser. So focal laser, even though it was a standard care, it is not still the best option, because we are creating unnecessary collateral damage to the critical areas of the retina. So then came the first injection, that was triamcinolone, which is an off-label use, which was mainly used for orthopedic surgeons. And we were injecting this in patients, especially with the diffuse macular edema, because focal laser used to work well for focal maculopathy, but for diffuse macular edema, the grid laser was not that very effective, and we used to have very poor outcome. And in those days, the first godsend gift was triamcinolone. So, but the problem with triamcinolone, you can see, as you all know, the cataract as well as glaucoma, plus the rebound effect. So, when you have third or fourth injection, the response to the injections down the line is less compared to the first. First injection will work like magic, but the later on injections do not work that very well. Just showing some response to the intravitreal injection in one of our old cases. So this is mainly acted by making the blood retinal barrier more stronger, as well as had a smaller effect on the VEGF component also. So mainly thereby decreasing the capillary leakage and decreasing the fibrin deposition. And also in the chronic macular edema, you have a component of inflammatory component, and this was mainly taking care of those cytokines involved in this DME pathway. Then to decrease the side effects of steroids, we had the era of anti-VEGF. Macugen was the first, mainly for AMD. Then we had the Avastin, Lucentis, and the Eylea. So amongst this, Avastin is the most popular because of the cheap cost, but otherwise the standard of care has been Lucentis, and nowadays it has shifted to Eylea. In outside countries, now the standard of care is Eylea for DME. So there are multiple trials showing the efficacy of these drugs in patients with diabetic macular edema, and there's a lot of studies for all the drugs, aflibercept, Lucentis, as well as they showed the efficacy and the safety also. But you look at which drug works well amongst the three. we had that in eyes with poor presenting vision, aflibercept was better, but otherwise in patients with low minimum vision loss, there was no big difference amongst these groups. So also if you see that the persistent macular edema was lesser with aflibercept, and the worst was with the bevacizumab or Avastin. Avastin had the persistent edema, more risk of having a non-resolving edema down the line at the end of 1 year follow-up in one of the studies. So then we had the protocol T extension study, which showed that the protocol T showed that aflibercept was better in eyes with poor visual acuity. But the extension study showed that even after after 2 years, people still had edema, and when they were left to the doctor's discretion, the outcomes were not that very good. So the vision did not improve beyond 2 years, and a lot of people tended to lose vision, but most of the patients were tended to maintain vision. But the improvement in vision was not able to sustain after the 2 years study period. So then there was to decrease the treatment burden. So there are a lot of things have been coming up. This is one of the devices from the Novartis and Roche. So this is actually sort of an implantable depot. So because they could not make the Lucentis to act longer, you just insert this depot into the eye, and then you can fill it up whenever you want. And once you fill it up, it works for 6 months. So you just implant this device and then suture the conjunctiva and tenons over it, and every time you have to inject the drug into this reservoir. But the problem with this was that the septum which holds the drug inside tended to dislocate, and almost 3% dislocation was seen in the first study, and now it's not in the market right now. It's still called back, and I don't know when they'll reintroduce this. This was able to sustain the efficacy of ranibizumab for 6 months. So to increase the duration, then we had the advent of Ozurdex also, which promised a 3 months follow-up, efficacy on follow-up. And then the Iluvien implant, that is very good because we had 2 formulations for Iluvien, just showing a video of the Ozurdex injection. So the Iluvien implant also is a small pellet, whereas Ozurdex is a biodegradable vehicle, so the whole pellet dissolves, whereas the Iluvien implant, which has the fluocinolone acetate inside this dexamethasone insert, but the Iluvien is similar, everything is similar, but you have a non-biodegradable pellet sort of thing. So you have 2 membranes through which the drug will perfuse into the vitreous cavity, but the vehicle itself will remain for lifetime. So this is the response to Ozurdex. And this is the Iluvien implant, which is here, this is a non-absorbable pellet. So drug is inside, and you have 2 permeable membranes through which the drug will be slowly released. We had 2 formulations, one was 0.2 and 0.5. 0.2 worked for 1 year and 0.5 worked for 3 years. It was super efficacious, but the side effect was very high. So we did around 35 cases in our hospital. So it was we had almost 100% cataract at the follow-up of 2 years, and almost 30% had glaucoma, of which probably 10% needed glaucoma surgery. So because of these complications, FDA did not approve it for routine use for diabetic macular edema. Then we had the advent of micropulse laser to decrease the collateral damage. Instead of a continuous laser, we had delivery of the laser beam in small packets, so that before the heat can permeate into the retina and cause collateral damage, it stops. So the choroids get heated, and then before the retina achieves the whitening, the laser is stopped. So here, how does it work? It mainly induces a lot of reparative process, and also some formulate that it acts on the tumor necrosis factor alpha. So thereby, the reparative process helps to resolve the edema. So this is how the micropulse works. Before the retina gets burnt, the laser stops. So mainly it inducing some sort of reparative process. The exact mechanism is still not known, but they say that tumor and TNF alpha plays one of the major role, and this is the parameters which are routinely used. But even though the results, the trials were very promising, in real life scenario, it was not very promising at all. We had a trial between Arvind Madurai and the LVPI Hyderabad. So they had to stop the trial in between because the response was very poor. So even though the company-sponsored trials showed very good response, it was not able to replicate in real life scenario. And this is one of the cases where you can see the laser is being done. So first the energy is titrated, then it's converted to a 5% duty cycle, and then you can see the laser being delivered. So you'll not have any perceptible burns after the end of this. Actually a CSR case. You can see the micropulse laser being delivered. So you'll not see any endpoint here. Unlike routine focal laser, there'll be no whitening, so there's no collateral damage. But the real world scenario, the efficacy was not as described in the trials. Then we had the new drug which came to the market right now, the Peginax or brolucizumab. It offered 2 to 3 months efficacy. It's mainly a humanized mononuclear single chain variable fragment. that works on VEGF-A. So a lot of trials showed that it is efficacious. Some trials showed it's better than aflibercept, but clinically, if you see, we are also using it. But unlike AMD, where brolucizumab has a super efficacy, it is not so in DME. DME has only very moderate efficacy, more or less equal to Lucentis or aflibercept. So maybe the duration is slightly longer, but the efficacy-wise, it is not that very spectacular. But if you do in a ARMD, the efficacy is very spectacular. DME did not show such great results. So some trials showing the response to brolucizumab, and this is a very large trial with more than 650 patients. They showed that it was more or less equal to the aflibercept. It was not very big. Only thing that it may have a slightly longer effect than the Lucentis. Then we have the new drug which is coming into the market right now, that is faricimab. It's a bispecific monoclonal antibody which acts on both VEGF-A and angiopoietin. Angiopoietin mainly sensitizes the tissue for the action of VEGF-A, and also it has got minor action, so it helps to directly inhibit VEGF also, but it both acts directly on the VEGF and also helps to suppress angiopoietin, thereby decreasing the sensitivity of the tissue to VEGF-A. So the efficacy here is proven to be 3 months, and people are very happy with the efficacy. It really works for 3 months, which unlike brolucizumab, which was not really giving that much long effect. So the Bolivar trial, which is a major trial, showed that it is really efficacious, and you can give it once in 3 months, 3 to 4 months, especially in some of the trials they showed that. So this is about the drugs itself. Then there have been a lot of research going on into how to enhance the efficacy of the currently available drugs. So topical, now one new drug is going on trial in Arvind. So, but main barriers for topical delivery is that the lot of washout happens at the tear film, corneal, and the aqueous. So a lot of things get washed out. People have also tried conjunctival transscleral effusion, but there also the choroid tends to suck off all the drug, thereby limiting the retinal exposure to the drug. So there's have been a lot of barriers here. But right now, a lot of research is going on into this non-biodegradable implants, nano formulations, and hydrogels. But till now, there is no promising drug in the market at this point of time. One drops is just entered for trial, so we'll have to wait and see how that performs. So these are now current directions to enhance the efficacy of currently available drugs, and most of these drugs have been using Avastin as a molecule for them. So these are the parameters which they are looking at, how to enhance the what are the requirements for a correct delayed drug delivery system. So right now Avastin is going a lot of drug trials in these formulations. And the last thing we will be trying to say is the gene therapy, where here we are using a adenoviral vector and using a functional gene, and this is either injected in the subretinal space or the suprachoroidal space, and it will be acting like a biofactory inside the eye. So this will be producing the VEGF inhibitor inside the eye. So we do not inject separately, the gene will be producing. So this is showing the Region X bio trial, where the approximately 250 microliters of 3 billion gene copies are injected in the subretinal space after doing a vitrectomy, and fluid exchanges are done after this, and then it is closed. So minimal vitrectomy, subretinal injection of the genes. So now these genes will be sitting using adenoviral vector, and these genes will be sitting in the eye permanently, and you have a permanent biofactory inside the eye. So this will be used to these will be manufacturing the VEGF inhibitor right inside the eye, so there's no need to inject it later on. So there is one more trial which has been showing some promising results. One of the Indian is only doing the main, this is again by the AbbVie, or the now Allergan, which has been taken over by AbbVie. This is the RGX314 gene, and they have 6 months results have been very promising. They show that it's equal to steroids in decreasing the diabetic macular edema, and this is how it is given in the suprachoroidal route, a short needle, so that doesn't penetrate the choroid. So it is given in the space between the sclera and the choroid, and this tends to permeate. And so both gene therapy has been tried in both these routes, both subretinal as well as suprachoroidal. And these are some of the newer directions which are looking at to enhance the efficacy as well as to prolong the effect of the currently available drugs. Thank you. I'll stop here.
Thank you, sir. That really was the telling you what is happening in diabetic retinopathy. Now my talk is going to be about why we want to do all this. Why are we so bothered about getting more and more newer things? So you will be here for some time. Okay.